Good evening, everyone. I am Dr. Sachin Patil, MAHAIP EB 2025, along with my friend Dr. Nikhil Patak, EB Central IP 2025. Welcome you all on this 8th episode of Friday Ka Punch MAHAIP Ke Sang. Tonight we have assembled with exceptional panel featuring almost 5 distinguished speakers, each representing one of the Maharashtra's zone, and two eminent experts in the field. So today's topic is common surgical emergencies in pediatric OPD practice. So definitely we will be thrilled to share this knowledge and insights and experiences with you. Your participations and engagements are invaluable. So if you have any questions, please put in the chat box. We will definitely take all questions at the end of the sessions. Now I request our respected MAHAIP President Dr. Sanjay Pakmode sir for the welcome address. Over to you, Sanjay Pakmode sir.
Thank you, Sachin. Namaskar. Welcome to the MAHAIP platform. Now, this is the 8th episode of Friday Ka Punch MAHAIP Ka Sang. The beauty of this program is where we foremost important thing is the inclusiveness, which is nowadays very difficult to find, either in the science or the IEP platforms or the politics. So here, one speaker is representing one region. That's the beauty of this particular program. So all the speakers from all the 5 zones of Maharashtra are there, and they are presenting on particular topic. And today's topics are pediatric surgical emergencies. No doubt, we as a pediatrician, we are not very much interested in the surgical conditions, but a patient encounters for the first time with you, and it is your duty to diagnose rather as the years pass by to give him the right diagnosis. And while referring in the referral chart, you should write a proper diagnosis so that you have diagnosed the patient, but since the condition being surgical, you are referring the patient a competent authority, that is a pediatric surgeon. So that means you are doing the justice with the patient. So that is one thing we must know. So we thought, even though we deal with the pediatrics in general, but we must know all areas of pediatrics. Because if we are like a family physicians or like a family pediatricians, so we are treating all the conditions, whether it is growth, whether it is development, whether it is immunization, so whether all the aspects related to the pediatrics. So this is one area where also we need some knowledge as well as the proper time referral, because in all the conditions the outcome will depend on what time you have referred the patient to the consultant pediatric surgeon. So if we encounter such patients, so we must rightly diagnose it, rightly write a referral letter to the pediatric surgeon. Rather, we can inform him, some and so patient came to me and referring the particular patient to you for the surgical intervention, so that he'll be prepared and patient will be benefited. So that's why we have arranged this particular program for the MAHAIP platform. And today I welcome you, all of you, all the MAHAIP office bearers, CIP office bearers, and today's experts, Dr. Shailesh Barot from Palghar and Dr. Usha Gajbhie from our Vidarbha only, Amravati, and all the speakers, Dr. Tushar Hire, I think is the Secretary Malegaon, Sandeep More from Pabhani, Sanjeevani More from Raigad, and Abhiraj Parikram from Wardha, and Sachin Jangam from the Sangli. I wish you all the best for the presentation and hope every attendees will get or will be updated about all these conditions. So over to you, Sachin.
Thank you, Pakmode sir, for your blessings and insights. Without further ado, I will request Dr. Amol Pawar sir, HSG MAHAIP.
Thank you. Thank you, Dr. Sachin. On behalf of Team Maharashtra IIP, I welcome all the dignitaries, all the office bearers of district branches, as well as from state office bearers, then all the central IPEBs, and both the experts, my mentor, Dr. Shailesh Barot sir from Palghar, then Dr. Usha Gajbe ma'am, senior pediatric surgeon from Amravati, and all the 5 speakers, Dr. Tushar, Dr. Sandeep, Dr. Abhiraj, Dr. Sanjeevani ma'am, and Dr. Abhiraj. So this is very nice idea that young speakers are given a chance to showcase their oratory skills through MAHAIP platform. And even though we do not manage, but we diagnose these cases and we refer timely to the pediatric surgeon so that the conditions get corrected timely. So we'll be hearing all the nitty-gritties of these common conditions which come across in our office practice, and experts will be guiding speakers as well as all the pediatricians and PG students as well. It is my good luck that Dr. Sukanta Chatterjee, he is a very great adolescent expert and senior executive board member of Central IIP. He is with me. So I just want him to speak for a few words. Sukanta sir.
Okay, good evening, and it's a privilege for me to speak in this forum. And Dr. Pakmode, the president, sir, and Amol, my younger brother, and all the dignitaries present here. I'm very happy that you have chosen such a topic that it is very much related to our daily day-to-day practice, and this sort of integration of services between the pediatrician and the pediatric surgeons are very important for the service of the pediatricians and the patients. So I'm very happy that you have arranged it, and thank you very much. It's a great opportunity for me to meet you here. Thank you.
Over to you, Sachin.
Thank you, Amol sir, and thank you, sir, for your blessings. Now, for further proceeding, I request Dr. Nikhil.
Good evening, everyone. I am Dr. Nikhil Pathak, Central IIP member from Chhatrapati Sambhajinagar. So taking the program further, next I would like to invite Dr. Sanjay Deshmukh, convener of MAHAIP, to get a few words on this occasion.
Good evening. Welcome to the MAHAIP academic platform. Since the beginning, you know, every month, every Friday, we have one super specialty series. And today we are discussing pediatric surgical emergency. As we are practicing in Metro City, we have a luxury of pediatric surgeon beside us for 24 hours. Nikhil must know. But for the common pediatrician in smaller places, it's very difficult to diagnose and refer immediately. So early diagnosis and refer is must. And I think this is a great platform. Today we are discussing this common pediatric emergencies by all young pediatric all over from Maharashtra. My best wishes to all the speakers. I'm thankful to today's expert, Dr. Bharat sir and Dr. Usha Gajbe madam. She is a senior most pediatric surgeon for Amravati. And best wishes to dynamic Jodi, Dr. Sachin and Dr. Nikhil Pathak. So let's enjoy the academic feast. Thank you.
Nikhil, 1 minute.
Yes.
Minhas sir is there?
Minhas sir has joined just now.
Yes,
sir.
Yes. Our condolences from our side. Sir has lost his brother just 2 days back. So we from the MAHAIP platform offer our heartfelt condolences, sir.
Om Shanti.
Thank you. Thank you, Sanjay.
So let me take the program further. So let me first introduce our two experts, Dr. Barut sir, who is at Palghar. He is the director of Ankur's Pediatric Multispecialty Hospital. And most of the juniors know him that once you complete your MD or DCH from Mumbai, for all the practical experiences, many of my friends have worked with him at Palghar, and he has a huge experience with multiple patients and such a large experience. So from pediatrician point of view, he is the today's expert for us. Next, when you are having a pediatric surgery thing, we need a pediatric surgeon with us to explain about all the conditions. So we have Dr. Usha Gajbe. He is an MCH pediatric surgery, fellowship from Australia in pediatric surgery. she has been working as a pediatric surgery consultant at Matruchaya Hospital at Amravati as director as well as owner. She is at the regional referral services at hospital at Amravati at consultant pediatric surgeon and also at PDMC College, and has multiple national and international publications. She has a special interest in pediatric urology, minimal invasive surgery, and neonatal surgery. So I welcome ma'am to this platform and give her expert guidance to all the fellow speakers. Now coming back to the speakers. So first we have from Malegaon, Dr. Trushar Hire. So he's a consultant pediatrician from Malegaon, and he is at present the secretary of Malegaon IAP. So I welcome Trushar here. We were all waiting eagerly whether Trushar is joining or not. So, so he has joined with us. So let us welcome. Next, I would like to just make two references. Dr. Sandeep More is my undergraduate batchmate from MGM, and he does not pick up my phone. So this platform has a way where I can connect with him. So I welcome Sandeep. He is a leading pediatrician in Parbhani, and he has done his DCH DNB from Nanavati Hospital. So kindly pick up my phone next time, Sandeep.
Yes, sir.
So, so that way. Next, I would like to again introduce Dr. Sanjeevani More. She has been my batchmate at KEM Hospital, Mumbai, and at present working at Urun. And she has a special interest in infectious disease and adolescent. So I welcome Sanjeevani again to this platform. Next, Sachin Jangam. Sachin is a very close friend, and he is a pediatric intensivist at Sangli. And he does a very good intensive work at Sangli and is a director at Intensive Care Hospital. And he's very busy. At present also, I think he's busy attending one patient, so he will be joining us within 5 minutes. And last but not the least, Dr. Abhiraj Parekar. He is the intensivist from Wardha and is attached to the medical college there. We all welcome him to this platform. So I welcome all the faculty to this program, and we can begin with the thing. So first presentation by Dr. Trushar Hire.
Just 1 minute, Nikhil. We request Dr. Shailesh Barot sir for words of wisdom. Please, sir. Barot sir. Yes, sir. Few words, sir.
Pediatric surgery emergencies. If we miss the bus, then we'll end up in problem. So early pickup and early treatment, early reference is the only thing which can prevent the child into complications and the child getting admitted in ICUs. So I think you should have a vigilant ear and pick up the things early. And today we are going to learn from all the experts and all the speakers. Thank you.
Now I request Dr. Gajbe ma'am. Few words of wisdom.
Sir, I actually told everything about the emergencies. It's really, you have to be very vigilant, and all the pediatricians and even the resident, they should know what are the pediatric surgical common problems and how they present, and that will give a better early diagnosis and outcome also.
Okay. Thank you, ma'am. Over to you, Nikhil.
So, first presentation by Dr. Trushar Hire. Trushar, can you share the screen?
Yeah.
Trushar will be speaking about obstructed hernia.
Oh, yeah.
So let us have his presentation.
No. Hello.
So, are you able to share PPT?
Now, I just want to share some. एकच मिनिट. Obstructed hernia is common in males. Indirect is 99%. 1 to 3% of all children, 3 to 5% in preterm baby. Right side 60%, left side 30%, bilateral 10 to 5%. Males and females ratio is 6:1. Present as bulk in groin, scrotum and labia. A reliable history is sufficient to make the diagnosis even if the hernia is cannot be defined. An increased inguinal hernia present as a mass in the labia or scrotum that does not reduce spontaneously. What is the embryological event account for this abnormality? There is a failure of processus vaginalis. The hernia should be repaired actively. The parent should be warned about possible incarceration in the meantime. If at the time of your examination the child was irritable and the mass is reducible, what should be our approach? If mass is reducible, what is your approach?
There is no interaction.
Pediatric surgeon.
Usha ma'am, Dr. Hire wants to know if the mass is reducible. So what should be the approach from the pediatric surgeon and how we can approach further?
If mass is reducible, what is your approach?
See, if I get a child with a irreducible inguinal hernia, you have to see how many days the child is having such symptoms.
Okay.
Is there any abdominal distension? Is there any vomiting? If the child is irritable and whether he has passed a stool or not. And what is the hydration status of the child? If the history is just for few hours, you can actually reduce. If the child is okay, you can just give some sedation, or otherwise just reduce it with your hands, and that will you will be able to reduce it, and then you can operate next available OT, because if you try to do it immediately, there is a lot of edema in the inguinal region and the surgery is sometimes difficult. But if there is no, the history is long duration and there are signs of obstruction, you have to go for a surgery after investigations.
How to differentiate between normal obstructed hernia and incarcerated hernia?
There are obstructed hernia, there will be signs of obstruction.
And what about incarcerated hernia?
Incarcerated hernia, there is a irreducible swelling, but there are no signs of abdominal distension. There is no green vomiting, and the child is just having a inguinal swelling which is irreducible for a couple of hours or maybe 5-6 hours.
What
So,
is silk glow sign?
sorry,
Silk glow sign.
बोल हाँ बोल
silk glow sign as such, I'm not aware, but then you should differentiate whether there is a signs of irreducibility or obstruction. Irreducibility, it's incarcerated is just obstructed, incarcerated for a couple of hours or maybe 4-5 hours. But obstruction can be there for a day or two. And in that obstructed cases, you have to do it immediately after the investigations.
But it is very difficult to diagnose the inguinal hernia in female patient.
No, not really. You can see if the child is coming to you and saying the child is having a swelling in the inguinal region and it's not going. In female, most common organ which comes in the inguinal region is
Ovary.
ovary. Sometimes bowel also comes. So ovary is
Ovary is look like testicular.
no.
Ovary is look like just testicular swelling.
But what do you want to ask? I'm not getting it because see,
How to confirm that it is hernia in females?
the swelling comes and goes, no, sir?
Okay.
Swelling comes and goes. If it is irreducible, the swelling will stay there, and if you press it, it won't be able to reduce. That is irreducible swelling in female, and ovary is quite resistant for a the blood supply remains for a long time. It won't get gangrenous for a long time. So the pain is there, swelling is there, and the child is irritable. And it's in the inguinal region. So, and it won't, most of the time, it won't go in the labia. It is there in the inguinal region only, most of the time.
But pain, nausea, vomiting, that are the confirmed symptoms in female also?
If it is irreducible, it is there.
Okay.
Pain is there, but signs of obstruction won't be there if it is not a bowel. If it is a intestine, then there will be signs of obstruction. Vomiting, nausea will be there. And if it is a ovary, pain is more common and irritability.
Thank you, ma'am.
Thank you.
Thank you very good discussion.
Yes,
Sachin, then
yes,
can
next
we get
speaker, we will go with the next speaker.
Thank you.
Now the next speaker is
Sandeep More.
Dr. Sandeep More, sir. The topic being testicular torsion. Dr. More, sir, over to you.
Yes, sir.
Sandeep, can you share your PPT?
Can everybody see?
Yes.
Yes.
Yes. Okay. Good evening, everyone. I'm Dr. Sandeep More. I'm practicing in Parbhani as a pediatrician since 20 years. Today's my topic is testicular torsion. Okay. Supposing. Just a minute, sir. Yes. Now, definition and epidemiology. The torsion refers to the torsion of the spermatic cord structures, subsequently the loss of blood supply to the ipsilateral testicle. It is time-dependent urological emergency as it should be timely evolved and timely surgical intervention should be there. That's why it is timely dependent. In 65% of cases, they occur between 12 to 18 years of age, but can also occur at any age, including neonate, infancy, till adulthood. Early diagnosis is the key, as the testicular viability significantly decreases 6 hours after the onset of the symptoms. The etiology behind this, it is typical due to congenital abnormality of the processus vaginalis, a blind-ended evagination of the abdominal wall that developed during the fetal development. Its onset is spontaneous, exertional, or with the trauma. During sleep also it can occur. Tunica vaginalis usually solidly adheres to the posterolateral aspect of the testicle, and within it the spermatic cord is not mobile. If the attachment is high enough, then this allows the spermatic cord to twist intravaginal torsions. Bell clapper deformity, allows the testicle to move freely like a clapper in the bell, as it's bilateral in at least 40% of the cases. On the other hand, neonate tends toward the extraversion because of the tunica vaginalis does not adhere to the caverniculum. Okay. Then with the bell clapper deformity, it allows the testes to move freely like a clapper in a bell, and it is bilateral in at least 40% of the cases. Unlike the older individuals, neonate can experience the extravaginal torsion because their tunica vaginalis has not yet adhered, leaving the entire structure at risk. It's important to know that neonates are also present with intravaginal torsions. Torsion is known to occur in presence of malignancy in adults. These are some pictures. The left one side is the normal with the posterolateral adherence of the epididymics and structure to the testicles. Extravaginal torsion, including the vas dependent spermatic cord and epididymis, tunica vaginalis, all. Intravaginal torsion is the only structure inside the tunica vaginalis is going twisted, and the bell clapper deformity is the dorsal dorsal adherence of the epididymis to the testicle, giving the freely mobility to the testicles. The pathophysiology. In the torsion, it rotates between 90, 180 degree to 360 up to 720 degree also it can rotate. The complete rotation is above 360 degree or more. Twisting causes first venous occlusion, engorgement, then arterial ischemia, and eventually infarct of the testicles. Testicles become tender, swollen, and possibly erythematous. Complete torsion is rare, but decreases the viability of the testes. Extravaginal torsion, most common in newborn without bell clapper deformity, it causing the torsion of the cord at the level of the external ring. And the intravaginal torsion, the more common type, occurs most frequently at puberty. Condition linked with the bell clapper anomaly in this. The symptoms. Severe scrotal pain is mostly unilateral. Nausea, vomiting, abdominal pain, and fever related to the activity, trauma, or during sleep. It's also associated with previous episodes similar and spontaneous resolution, intermittent type. Now examination part. Unilateral firm testicle is there. Scrotal edema, and swelling. The affected testicle is typically higher than unaffected one. The testicle may be in an abnormal or transverse lie. Negative Pern sign is there. What is Pern sign is relief of scrotal pain by elevating the testicles. Negative sign indicates no pain relief, which points toward the torsion, but it is not reliable test. Then loss of cremasteric reflex. It is also not reliable as it is once thought it reliability. It is unreliable in young patient under the 1 year of old age, and mostly In 30% of the normal people also, cremasteric reflex is not present bilaterally also. And when we are examining the baby, first we have to do the cremasteric reflex on the unaffected side. If the cremasteric reflex is present on that side, then check on the affected side. Now come to the differential diagnosis. It is epididymic, orchitis, inguinal hernia, symptomatic hydrocele, scrotal hematoma, testicular necrosis to the other etiology, and torsion of the testicular appendages. Epididymitis, orchitis are usually very confusing with the same one, but with the inguinal hernia, indirect hernia, as we see, it is usually for long time presentation and obstructed at a particular time. Symptomatic hydrocele, it's also a prolonged disease, not suddenly pain appears in that. When about the scrotal hematoma, it is due to associated with some trauma or injury. It is should be differentiated by doing the imaging. Testicular necrosis due to other etiologies, it is also require imaging. And torsion of the testicular appendages, the pain is typically on the appendages, not on the testes. When you press on the dorsal side of the testes, then only excruciating pain is there, but not on the testicles below it. Now the evaluation. There is a testicular workup for ischemia and suspected torsion, the scoring system twist. It includes the pointage like hard testes 2 points, swelling 2 points, nausea, vomiting, absent cremasteric lepse, cremasteric reflex, high riding testes, 1 point each. Now, if the score is low risk, score is 0 to 2 points, then it's low score, suggests very low probability toward the torsion and often 100% negative predictive value. But with the intermediate one, this category require further investigation as a scrotal USG to confirm or to rule out the torsion. With the high risk, indicate high probability of torsion and required immediate surgical intervention. Either ultrasound is available or not. Diagnosis. The history, physical examination, and imaging. 3 are most important for the diagnosis. The imaging is imaging of choice is Doppler ultrasound. Diagnostics test of choice, Doppler ultrasound, testicular arterial flow absent in the torsion. And in a patient with high suspicion of torsion, emergent surgical consultation should not be delayed by diagnostic imaging. Like if in the night hours, we have a patient to complain and high probability of torsion, then we should not delay the surgical intervention for the diagnosis, because last line is time is testicle. If the 6 to 8 hour window period we lost, mostly we will lose the testicle. Now this is imaging of early torsion 4 to 6 hour. As we can see, there is no flow. Echogenicity is similar. Grayscale color flow pulse Doppler sonography reveals absent perfusion to the left side of the testicles. Left testicle is mildly enlarged. Echo texture of the testis is normal and scrotal wall thickening is present. While in the late torsion, with prolonged torsion, testicles are typically hypoechoic and have heterogeneous echo texture, which implies necrosis. Surgical salvages of the testicle now unlikely. Now management. The suspected torsion, immediate surgical exploration with intraoperative detorsion or bilateral archaeopexy to the scrotum. Orchidectomy if non-viable testis, and if not immediately available surgical exploration, then manual detorsion like medial to lateral, like opening of a book, rotation of the testes should be done. May need to rotate 2 to 3 times for complete detorsion. Regardless of the success, all patients require surgical evaluation as it tends to revert. The two pictures we are seeing, the detorsion and bilateral orchiopexy earlier in the earliest one, and the second picture is necrotic orchidectomy, late torsion we are seeing. Now to the prognosis. Best result obtained if surgery is done within 8 hours. Recurrence can occur after orchiopexy also. Now it's the complication. Most rated complication, loss of testis. Second is infection, infertility, cosmetic deformity, and loss or diminished exocrine and endocrine function in a male. Thank you very much.
Thank you, Sandeep. Now we will have some expert comment from Barot sir first, and then the final closing remarks by Usha madam. Barot sir.
So whenever you see a red scrotum, don't give proper instruction and advice to the patient that you have to keep in mind. One is henoxonal purpura, where the rash comes later on and the red scrotum or the orchitis can come first. So later on, if the rash comes up and then we explore the patient, then at least the patient's relative should know that you were explored because of the red scrotum, but then the rash has come later on. That is one part. Torsion is a medical legal, you have to keep medical legal things ready, because later on the relatives can sue you that you have referred to me later on and the testis is now non-viable. So you should always write down time, date, and the condition of the patient whenever you see the patient first, and write it down on paper that you have referred this child to this pediatric surgeon at this hour of time. Third thing, that any red scrotum, you don't wait. You don't, it is not a point that it is orchitis and we will wait with the antibiotics. You will miss the bus. So any red scrotum is an emergency. Even if you are in a very distant area where the pediatric surgery facility is not available, please refer the patient in the night also. If there is no USG facility available, still the patient, please refer the patient. Don't make them wait in your consulting, or don't make them wait in your hospital that tomorrow morning the pediatric surgeon will come and then see. It's a medical emergency. You are absolutely right about the twist scoring. Manual detorsion should be done only in a setup where complications can be handled. Don't do manual detorsion in your clinic because the pediatric surgery facilities are not available in your area, because you never know that whether the testis is twisted on the right side or left side, and you may compromise more that testis rather than helping out the patient. There is a testicular salvage rate. If the testis, if you have done the treatment in 3 hours, there is 100% chances of salvaging. 8 hours, the rate comes down to 75%. At 10 hours, it is 50 to 70%. More than 10 hours, it is 10 to 20%. And after 24 hours, there is a 0% salvage. Even if the testis is not salvageable, you have to always open up the other side of the scrotum and you have to fix the testis, because there is a chance that the other testis can also go and have torsion in the later on age group. If one testis is having a chance of torsion, the other testis can also be having a chance of torsion in later age. In a neonate, if you see an absent testis on one side, there is a chance that in the entire life, the child may have had torsion and that testis may have vanished. So in an absent or undescended testis, and on USG or on MRI, if you can't find a testis, then there is a chance of torsion in the intrauterine life. And in a less than 1 month old child, always open both sides if you are suspecting a torsion and fix both the testes. Don't leave them alone. That is it from my side. I'll hand over to pediatric surgery side.
So Usha ma'am, your closing remarks. With one question from my side, if you have done an orchidopexy, what is the role of cosmetic surgery with artificial testes and when it should be done? So orchidectomy, not orchidopexy, sorry ma'am.
Sure. I'll answer your question at the end. I would like to add to the sir's remark that sometimes the torsion can present as an abdominal pain also.
Yeah.
So we should be able to examine the patient. The genitalia should be examined along with the abdomen if the child present with abdominal pain. I have witnessed such case in Australia when I was there, that in 18-year-old boy who had orchidectomy in the newborn period or early age, orchidectomy was done for something, and then later he presented at 18 years of age with the abdominal pain, and they opened for the appendicectomy. Later they found that the testis was like torsion was there, and it was already gangrenous. And they did the appendicectomy. They didn't do the orchidopexy because consent was not taken. And to our surprise, that surgeon was actually, his license was cancelled. So one should be very careful in examining the patient abdomen and the genitalia if the child present for abdominal pain also. And one more thing is negative exploration. Like if you get a child with the torsion of the appendages, of the testicular appendages, negative exploration can save you. But the if you miss torsion, nobody is going to save you. So early intervention. And one more thing I would like to tell, I think we should tell that schools also, and even the awareness in the general public should be there, that if your child is having a pain in the scrotum, always take your child to the surgeon or the pediatrician immediately. Don't miss the time. So this is the thing. And about the awareness about the pain in the scrotum. So all the family should be informed. And about your question, I'm going to answer this. This is done in adolescent period. The orchidopexy with the silicone testes. So
Thank
that
you,
is
ma'am. Thank
in the later period. The counseling of the family is important.
Thank you. Thank you very much, ma'am.
Thank you.
Further going, let us move on to the next lecture by Dr. Sanjeevani More. Sanjeevani, can you share your screen? Till she is sharing her screen, again, I wanted one comment, sir. So now you have USGs, you have color Dopplers, everything in hand. So, but when there was an era where this was not available routinely, so at that time, a surgeon would always like to open a scrotum and see the testes. That would be the gold standard. But
Yes.
Barot sir, how did you look at clinically that this? When did you put your foot down that this testis requires an exploration?
All red scrotum requires an exploration unless and until proved otherwise. Even if there is a USG which is showing a vascular patency, still I say that after 2 hours that vascular patency may not be there. So all red scrotum has to have a pediatric surgery opinion, irrespective of whoever he may be.
Thank you, sir. Thank you. So Sanjeevani, paraphimosis is a interesting topic which we see in our OPDs every day, mostly. So let's see.
Just second. Good evening, everyone. First of all, I want to thanks to MAHAIP and IIP Raigad for giving me this opportunity. Today, I am going to speak on paraphimosis and surgical emergency encountered by pediatrician. It's not moving, just wait. Paraphimosis is inability to replace the prepuce or the just extremely sorry. The paraphimosis is inability to replace the prepuce or the glans once it has been retracted. Inability to reduce the foreskin or stuck in interaction. We can
Hello. Sanjivni, your voice is not there. Unmute yourself. Hello, Sanjivni, now you can start.
Ma'am, click on the screen.
Yes.
Your presentation, huh? Yes.
Okay. We can see in this picture the swollen retracted, the swollen ring behind the penis. The causes are many, but most of the time the iatrogenic causes are like doing while penile examination or procedures like urethral catheterization, cystoscopy. The foreskin is pulled back, but fails to return to its normal position. Other causes are self-inflicted injury to the penis or while doing the vigorous cleaning, and second to penile erection. The pathophysiology is the foreskin is pulled back often during or often procedure. Foreskin fails to return to its normal position, forming the constricting band of tissue around the penile shaft, creates a physical obstruction. This leads to edema of the glands because of the restricted venous blood flow and lymphatic drainage. This causes the vascular engorgement. If the swelling worsens, it increases the pressure in the that ring. It causes the embitment of the arterial flow and potential ischemia. If it is not treated that time, it leads to compromise the blood flow of glands, leading to the irreversible tissue damage, leading to eventual necrosis. In diagnosis, there is no test as such for the diagnosis. It's a purely clinical examination. Diagnosis is made clinically by direct visualization as well as the inability to easily reduce the foreskin manually. In clinical presentation, it may occur at any age. The kids present with the symptoms like swelling, severe pain is there, penile pain is there, and sometimes a history of obstructive voiding. In past medical history, no history of circumcision, history of endoscopic surgery of the bladder or urethra, or recent procedures like catheterization. On physical examination, presence of the trapped foreskin, the color of the glands, like paleness or blueness of the glands indicates ischemia. We have to check for the degree of constriction and palpation of the glands for the tenderness. In management part, treatment modalities includes medical therapy and surgical therapy. The goal of the management involves reassuring the patient, reducing the prepucial edema, restoring the prepuce to its original position and condition. In pharmacological therapy, sometimes injection of hyaluronidase into edematous prepuce is injected to reduce the edema. It causes Dundee technique, and sometimes osmotic agents like mannitol or glycerin we can use to drain that fluid. In non-pharmacological, we can apply the ice packs and manual reduction. In manual reduction, as shown in the figure, a gloved hand is circled around the distal penis. A circumferential pressure is applied to disperse the edema. If manual reduction fails, then the role of surgical management comes. In surgical management, initially minimally invasive or dorsal slit or circumcision. In minimally invasive, the puncture technique, the multiple punctures are made in that swollen skin to reduce the edema or reduce the pressure. And in blood aspiration technique, we can aspirate the blood to reduce the pressure and fluid. If it not for, then dorsal slit procedure. It's bedside procedure. One longitudinal cut take over the edematous part and sutured it vertically to reduce the pressure and edema. In management, reassurance and vigilance. Proper preferential care and hygiene is more important, and role of topical steroid 0.05% betamethasone twice a day for 4 to 6 weeks. In surgical, conservative surgical like alternatives like prepucioplasty or Hindu circumcision and conventional male circumcision. Complication associated with paraphimosis is infection, swelling of the glands, ischemia, and necrosis. And complication associated with the dorsal slit, infection, bleeding, urethral infection, shortening of the penile skin. In management, conservative surgical alternatives, prepucioplasty, it preserves the foreskin, but disadvantage is recurrence. The benefits of circumcision is reduce the penile cancer, reduce UTI occurrence rate, reduce STI transmission rate, reduce cervical cancer rate in female partner, and recurrence of paraphimosis. Nursing intervention is encourage bed rest for a few days, instruct to avoid straddling activities, contact sports, and swimming for 3 to 4 weeks or until completely healed. Recommend sponge bath the day after surgery. That encourage hydration for the first 24 hours after surgery. Medication advised to take medicine as per prescribed by the doctor, like anti-inflammatory and antibiotic. Wound care, hand hygiene before touching the incision site. Encourage wearing loose fitting undergarment. Instruct to clean the surgical site with the warm water and pat it dry. Advise to keep the incision site clean and dry. And prevention was avoid foreskin retraction, good hygiene, care during procedure, circumcision in recurrent cases. Prognosis is good if treated early, but poor if delayed. The summary, it is a medical emergency, prompt recognition and timely treatment is must. Thank you.
Thank you, Dr. Sanjeevani. Bharat sir, for experts comment, please.
The most common cause in paraphimosis is massage वाली बाई. बाई मसाज करायला येते, पाठीमागे स्किन घेते आणि they come up with paraphimosis mostly during the day only. So oil massage is good, but not over there. Second thing is the ice application. When you do, you decrease the edema, means the edema will not progress so fast. Third thing, when you apply mannitol, you have to keep the mannitol for at least 30 to 45 minutes. Tight bandage of mannitol 30 to 45 minutes. So it decreases the osmotic edema, and then the reduction becomes very smooth. Fourth thing, when you apply the pressure, you have to apply very slowly, steadily, constantly till the skin comes back. You cannot be very jumpy here and there, because you will cause lot of laceration, and unnecessarily that will heal by fibrosis, and later on that child will definitely go for phimosis and circumcision. So that is the thing which is important, and you have to always rule out medical condition like nephrotic syndrome. If the glans is visible and there is a swelling, then it is paraphimosis. If there is a swelling with insect bite also, nephrotic syndrome also, so that you have to keep it in mind and make the relatives reassured. If you do not do the reduction early, then the ring around the glands becomes very strong, and then you have to go for circumcision. So earlier treatment, reassuring the parents, and slow and steady, and keep your cool. Most of them get reduced, madam.
Absolutely, sir. Right. First to come, first to serve, like that. First to take treatment and get rid of circumcision. Now, Usha madam, your experts comment on this topic, please.
Yes. paraphimosis is quite common. They usually come to the OPD, and you can reduce most of those cases. You can apply the xylocaine jelly, keep it for some time. I have rarely seen people doing aspiration or puncturing, which is more actually troublesome and quite invasive. So most of the time you will be able to reduce it. You have to give some local spray also you can use, or a xylocaine jelly. And those patients who cannot be reduced, you keep them nil orally and do it under anesthesia. And if needed, then you can go for a circumcision later on. So this is commonly done.
Thank you, ma'am. So now next topic is Dr. Nikhil.
Dr. Abhiraj. Dr. Abhiraj will be presenting acute appendicitis. It's a huge topic, and let's see how he gets through it.
Yes.
Abhiraj, please go ahead.
Yes, sir. Yes, sir. Sir, can you see me?
Pretty good.
Sir,
okay, it went off.
Yes. Sir, are the slides visible?
Yes, yes.
Yes. So thank you,
Absolutely.
Maharashtra IP, for giving me this opportunity. And I would like to thank my IIP Vardha also for giving me this opportunity to discuss this most common surgical emergencies in pediatrics, that is appendicitis in children. So I will be discussing introduction, historical background, anatomy, etiology, pathophysiology, diagnostic pathway, differential diagnosis, and most common management, and how to deal with the complications and outcome of acute appendicitis. We all know that appendicitis is nothing but inflammation of appendix, but we should also know the historical background behind it. So in 1886, Dr. Fitz, he coined the term appendicitis. In 87, Dr. Morton, he performed the first deliberate appendicectomy or perforated appendix in US. Next year, in 1889, Dr. McBurney reported the treatment of appendicitis with appendicectomy, which was done before the rupture. Looking after the incidence of appendicitis in children in India, it is one of the most common acute surgical condition, as I said, which leads to the childhood morbidity. In a lifetime risk, there is 9% of risk in a male child, whereas 7% in a female. The peak incidence is between 11 to 18 years of age, and it is more common in whites as compared to black. The peak incidence is in the month of October, that is at around autumn and spring. Coming to the anatomy, the appendix appears during the 8th week of gestation, and it is a continuation of the inferior tip of cecum. Appendix rotates to its final position on the posterior medial aspect of the cecum, about 2 centimeters below the ileocecal wall during the late childhood. Due to the variability of rotation, it has various multiple possible final positions as per the clock. So we'll be discussing that in next slide. Here you can see that there is various positions of appendix as per the phase clock positions. Out of all these positions, retrocecal, that is retrocolic appendix, is most common, which amounts for 64%. Subcecal position amounts for 32%, and pre and post ileal amounts for 3%. Now, it is very important to know the normal length of the appendix. So it averages around 8 centimeter in length, but it can vary from 0.3 centimeter to 33 centimeter. The normal diameter of the appendix ranges from 5 to 10 mm. The base of the appendix arises at the junction of 3 tinea coli, which is a landmark in order to know the exact location of appendix when we do open appendicectomy. The function of appendix is still not known as it is a vestigial organ. So coming to the blood supply, it is supplied by the appendicular artery, which is a branch of ileocholic artery, and it is an end artery. So it is very important to know the etiology behind the appendicitis. So exact cause is still not known, but it has been seen that it is associated with various factors such as appendicolith, fecoliths, decreased dietary fibers, increased amount of refined carbohydrates consumption, incompletely digested food particles, and lymphoid hyperplasia. It has been seen that the blunt trauma causes intraluminal scarring and it causes appendicitis. Few tumors and malignancies like carcinoid tumors and microorganisms, which includes bacteria, virus, and parasites, also leads to appendicitis. Now coming to the pathophysiology, as I mentioned, all this etiology causes obstruction of appendical lumen, which causes increased bacterial overgrowth, leading to inflammation, causing loss of function, pain, swelling, heat, and redness. The obstruction of appendical lumen also causes increased luminal distension and increased intraluminal pressures, which lead to inhibition of the lymphatic and blood vessels, causing vascular thrombosis, ischemic necrosis, and perforation. Perforation leading on to leakage of contents into the omentum and surrounding tissue causes complications such as abscess formation, small bowel obstruction, and peritonitis. Now coming to the clinical course, so appendicitis is broadly divided into simple and complicated. In simple, it is acute appendicitis, which is not associated with any perforation or peritonitis. Suppurative appendicitis, which is not associated with perforation, but it is associated with abscess. And complicated appendicitis includes gangrenous appendicitis and perforated appendicitis, which are lethal. Now coming to the clinical presentation of how appendicitis will present in children. So mostly children will lie in bed with minimal movement. The older children may limp or flex the trunk, and the infants may flex their right leg over the abdomen. So infants, they usually flex their right leg over the abdomen. This is a sign where we can rule out appendicitis. There are some classical features of appendicitis. It includes high-grade fever. The pain will start from the periumbilical region and then it shifts to the right iliac fossa later. It will be associated with anorexia, nausea, indigestion, and subtle changes in bowel habits, which is followed by diarrhea. So it has been said that the patient, if the person eats well, it is more likely that he has appendicitis. Now coming to the atypical presentation, which we encounter rarely. So if we are suspecting a retrocolic appendicitis, there will be tenderness on deep palpation, but the muscles will be not rigid. And the psoas sign will be present. That is the exacerbation of pain when the hip is extended. Now, if we are encountering a pelvic or subcecal appendicitis, so there will be rectal or vaginal tenderness and the abdominal tenderness will be absent. If we are encountering pre-ileal or post-ileal appendix, it is more likely the patient will present with vomiting and diarrhea. So appendix can also be found on the left side in less than 0.2% of population. So now we'll be discussing physical examination as it is the most common diagnostic tool when we don't have USG and CT with us. So presence of localized abdominal tenderness is the single most reliable finding in diagnosis of acute appendicitis. Other physical signs which we can see is temperature, that is high grade fever of more than 101, localized tenderness in the right iliac fossa, that is McBurney's point, and muscle guarding, there will be guarding rigidity and rebound tenderness. There are a few signs which we can elicit in order to rule out appendicitis. the 4 signs which we have to know is pointing sign, rousing sign, psoas sign, and obturator sign. Now we'll be discussing rousing signs. So if we are palpating the left lower quadrant, it causes pain in the right lower quadrant, then it suggests that there is appendicitis. Coming to obturator sign, if there is a spasm of the obturator internus when the hip is flexed and internally rotated, then if the appendix is inflamed, then it is high likely that it is appendicitis. So the digital rectal examination, it is also one of the diagnostic tool. But if these signs are not positive, then rectal examination is done. But if the signs are pointing out towards appendicitis, then the rectal examination is unnecessary. Rectal examination is done in pelvic appendix, and if there is a abscess in the rectovesical pouch or pouch of Douglas, so it indicates a pelvic appendicitis. Now it is very important to know the differential diagnosis of acute appendicitis. So we should broadly divide the differential diagnosis as per congenital, inflammatory, infectious, vascular, and genitourinary causes. So congenital causes, if there is an excruciating pain, and if the infant is taking his right leg up over the abdomen, we should think of Meckel's diverticulitis, duplication cyst. And if there is an inflammatory marker raised, then we should think of mesenteric adenitis, inflammatory bowel disease, intussusception, omental infarction. So infectious causes. So gastroenteritis is one of the most common differential diagnosis of appendicitis, which is mostly caused by bacteria, virals, and at times parasites. Vascular causes, Henoch-Sundlin purpura is also one of the DD of acute appendicitis. So in this case, usually there will be excruciating abdominal pain, which will be followed by purpura. So now coming to the genitourinary causes, we should also keep in mind pyelonephritis, because at times patient will come with hematuria in pelvic appendicitis, and we will miss appendicitis and will think of pyelonephritis. Nephrolithiasis, that is urinary stones, it is also one of the most common DD. The other most common DDs in females are ovarian torsion, ovarian tumors, ectopic pregnancies, pelvic inflammatory disease, and hemorrhagic ovarian cyst. Now coming to the investigation, as I said, there will be increase in the leukocyte count with mostly neutrophilic predominance. If the counts are more than 14,000 with high grade fever, then we are suspecting perforated appendicitis. Urinalysis, it has a limited role, but if there is hematuria with excruciating abdominal pain in the right iliac fossa, we should also think of pelvic appendicitis.
Abhiraj, Dr. Abhiraj, sorry to disturb
Yes.
you. Just 2
Yes.
minutes are remaining.
Yes, sir. Yes. So other investigations have limited role, like serum electrolytes, liver function test, CRP, tumor markers, tuberculin test, viral markers, beta HCG. So imaging, plain radiographs are usually done in a complicated cases where we suspect obstruction and air movements are less, bowel movements are less. USG, it is highly helpful if we are suspecting appendicitis, and if our Mantel scores are more than 7, or if it is between 5 to 7, we can take help of USG. The findings are usually wall thickness will be more than 6 mm. It will be associated with appendicolith, luminal distension, lack of compressibility, and complex mass felt in the right iliac fossa. We can also take help of computed tomography. It is a gold standard for diagnosing appendicitis, but it is generally avoided because of high radiation exposure. The findings will be always associated with more than 6 mm of appendical wall thickening, and there will be appendical wall enhancement as well. Now, as I mentioned before, there are two clinical scoring which we use. First one is Alvarado or Mantel scale. If it is less than 3, there is low likely that it is appendicitis. If it is between 4 to 6, then we can take help of diagnostic USG and CT in order to rule out appendicitis, and if it is more than 7, it is more high likely that this is appendicitis. We can also take use of appendicitis score, pediatric appendicitis score, which has 8 components and maximum score is 10. If it is more than 10, it is high likely. If it is less than 2, it is low likely. And if it is between 3 to 7, then we can take help of USG and CT in order to rule out appendicitis. Now coming to the management. So the most important thing is we have to rule out whether this is a complicated appendicitis or simple appendicitis. If it is a simple appendicitis, we can manage it with correction of dehydration, correction of electrolytes, and management of pain. But constant surveillance is important because anytime patient can go into complicated appendicitis. Now, as I said, the surveillance is important. So if you are working in a resource limited settings, it is very important to keep a watch and give a bowel rest followed by intravenous antibiotics. And if it tends to be complicated, then surgery is the gold standard and it has to be a choice of treatment. So when to refer the patient? So if the patient is having high rising pulse rate, increasing or spreading abdominal pain, and increasing size of mass, it is better that patient should be in a tertiary care center where the pediatric surgeon is available. For a complicated appendicitis, the majority of pediatric surgeon will perform appendicectomy within 8 hours. The opinion ranges from the non-operative treatment to aggressive surgical resection with antibiotic irrigation and drainage of the peritoneal cavity and delayed wound closure. So here we can see a photo of open appendicectomy, which is done with a incision at McBurney's point, that is cosmetic lance incision, and the layers of abdominal wall are opened. The mesoid appendix is ligated and then it is closed. So here we can see the photo of laparoscopic appendicectomy where the 3 trocars are inserted in the abdomen and the laparoscopic less invasive appendicectomy is done. Now, most common complication which we encounter after any surgical procedure is wound infection. Secondly, intra-abdominal abscess, paralytic ileus, adhesive intestinal obstruction, and fecal fistula. So, outcome, the mortality rate for complicated appendicitis has dropped to nearly 0% after the invention of appendicectomy. Antibiotics has markedly decreased the incidence of infectious complication, and the overall morbidity in a children with complicated appendicitis is less than 10% after appendicectomy. Now coming to the summary, the last slide. Appendicitis is common cause of abdominal pain in children. Repeated abdominal pain should not be overlooked and it should be high suspicion. A careful history and physical examination can reliably make diagnosis in majority of cases. Minimally invasive appendicectomy is a treatment of choice and post-operative management is determined by the operative findings. Thank you.
Thank you, Dr. Abhiraj. Now over to Barot sir. Especially, which patient of appendicitis we should admit, whom to refer. Sir, please unmute, sir.
Appendix is a googly in less than 2 years of age.
Yeah.
You should always suspect appendix. Even the child is irritable, lethargy, poor feeding, vomiting, diarrhea. They can also present, appendicitis can present like that. So suspicious of appendicitis is the single most important thing to prevent complications in younger children, because perforation rate is almost nearing 10 to 30% in less than 2 years. So by the time you diagnose appendicitis in a younger child, you have already, the appendix is already perforated and there is no other way you can do. Don't indulge them into conservative management. Regarding atypical presentation in preschool, if there is a diffuse pain, diarrhea, urinary symptoms, and sometimes retrocolic appendix can come with respiratory symptoms. So whatever the signs Abhiraj said are usually present in adolescent and they present like more than 15 years, they present like adults, but not in a very small children. Non-operative protocol, as Sachin was saying. So if the child is more than 7 years old, you have to try to conserve. If the count is between 8,000 to 18,000 WBC, less than 48 hours of history with mild pain and stable vitals, tachycardia, respiratory rate, temperature and BP. If they are stable, then only try to conserve. USG and CT shows non-perforated appendix and less than 11 millimeter in diameter, and absence of appendicolith, abscess or mass. If the patient is improved within 24 to 48 hours with your medical line of management, then only try to conserve, otherwise go for surgery. Second thing, what we have missed means we have overdiagnosed appendix in post-corona period in cases of MISC, where there was very high CRP, very high procalcitonin and severe pain in abdomen. And we have, in my hospital, we have opened up 2 cases of MISC and we found nothing, and appendicectomy was done unnecessarily. And then with IVIG, they got better. So I think you should have a very high suspicion of appendicitis in a younger age group. My surgeon friend will tell us better.
Yeah.
Sir, one more thing. What would be the drug of choice for conservative appendicitis?
In our setup, if the child comes with pain in abdomen and vomiting, and if we suspect appendicitis, first 48 hours we give only ceftriaxone and metrogyl. If the patient goes for surgery or anything like that, and if the thing found to be having an abscess or pus inside it, or if the patient is post-op bad, then we give piperacillin, tazobactam and metrogyl.
Thank you. Thank you, sir. Usha madam, your expert's comment, please. Madam, unmute, please.
The presentation was very good. Few things I would like to add. Fever doesn't come in the beginning. Fever comes when the child is about to perforate or already perforated. So don't wait for the fever to occur. It usually starts with the periumbilical pain and then radiates to the right iliac fossa. So any child with a nausea, vomiting and periumbilical pain, you can admit them and observe. I would suggest not to start the antibiotic in the beginning unless you do the ultrasound, because if you do the start the antibiotics, it will hide the symptoms, and usually we do not give painkillers in the beginning, because the painkillers, if you give, the symptoms of the appendicitis or pain will hide, and you won't be able to do it. So admit them, give IV fluids. If the pain is severe, then only give the analgesics. So, and do the ultrasound blood investigation. CRP is also useful along with the CBC. And if the child is not settling, then refer them. Most of the patients, it's like laparoscopic appendicectomy is done quite commonly, and in a day or two, you can send the patient home with the laparoscopic appendicectomy. It's very non-invasive and easy procedure. So, and in perforated cases or complicated cases, you have to definitely go for a surgery. There is no option, because it will increase the morbidity if not done.
Thank you, Usha ma'am. Now the last batsman today is Dr. Sachin Jangam. We will be speaking regarding the intussusception. Over to you, Dr. Sachin. Dr. Sachin?
Yes, sir. Good evening.
Yeah, please start your session.
Just 1 minute. My slides are visible, sir?
Please play the...
My slides are visible, sir?
Yes, slides are visible. Yes.
Yes, sir. Yes. So, I will directly starting my topic, intussusception. So definition-wise, this is a telescoping invagination of intestinal segment into the adjacent distal bowel. This is the most common cause of intestinal obstruction in infant and young children, which is common between 6 months to 36 months. Most common part involved is ileocolic. So most common age group is 5 to 10 months. Peak incidence is between 6 months to 18 months. There is slight male predominance. Incidence is 1 to 4 per 1,000 live births. And there is some seasonal clustering. That's why the viral association is suspected. So pathogenesis wise, there is a telescoping of a bowel which drags the mesentery into it. You can see the white arrow. It is called as intussusceptum. It's seen in telescoping into the intussuscipiens. That is a distal part, which is shown by the black arrow. So this telescoped bowel, which drags mesentery into it, causes venous congestion, edema, which progresses to the arterial obstruction, ischemia, and in untreated cases, it goes to the necrosis, perforation, peritonitis. So etiological, in 90% of the time, it is idiopathic. Some viral infections causes hypertrophy of Peyer's patches, and that is supposed to be a lead point. And in 10% of the cases, we may find pathological lead point, such as a Meckel's diverticulum, ectopic pancreas, polyps, duplication cyst. Sometimes we can see in inoculum purpura or lymphoma. So what is lead point? Lead point is a lesion or a variation in the intestine that is trapped by the peristalsis and drag into the distal segment, causing intussusception. So as I said, it can be Meckel's diverticulum, polyp, tumor, hematoma, or vascular malformation. So in general, there are two types. It can be permanent in 80% of the cases where the intussusception is a fixed and permanent, and patient is symptomatic and which requires the treatment. Sometimes it can occur as a transient event, and where spontaneous reduction is usually common, and patient is asymptomatic and just require a clinical observation. There are specific type idiopathic. Sometimes we don't get the pathological lead point. In specific pathological lead point, or sometimes you can get it after the post-operative cases, after small bowel obstruction, after laparotomy. Most common anatomical part involved is ileocolic. Sometimes it is ileocolic or appendicocolic or colocolic, jejunal or ileoileal. So clinically, the classical triad, which we say, which is rare, is seen in less than 30% of the cases, where is a colicky abdominal pain, when child screams, drags up the legs. There is vomiting, bilious. Vomiting is a late sign, as in any intestinal obstruction. The red currant jelly stool, which is a combination of mucus plus blood. There is a palpable sausage-shaped abdominal mass in right upper quadrant, and in that cases, the patient has lethargy, irritability, and shock. So this is a photo of a red currant jelly stool, which is a mixture of blood plus mucus. So how to diagnose it? In investigation, if we do the erect abdominal X-ray, in many cases, if we do it early, it may be not normal. And in sometimes it shows a meniscus sign or crescent sign. The gold standard to diagnose intussusception is ultrasonography, which shows a classical target sign or donut sign. In barium enema, it can show the coil spring sign, or barium enema can also show the filling defect with Krabs claw sign at the mid-transverse colon, as you can see in this picture. But the contraindication for the barium enema is a perforation, suspected perforation. Prognosis wise, with treatment and timely diagnosis, prognosis is very good. Post reduction, there can be a recurrence. Radiological recurrence is known in 5% of the cases. In surgical cases, it can be 1%. It can be fatal if it is left untreated. As a pediatrician, our role is to initial stabilize, get IV access, fluid resuscitation, correct electrolyte imbalance, nasogastric tube for the decompensation, broad spectrum antibiotics if perforation is suspected, pain and shock management, prepare for the radiological or surgical intervention. It can be treatment is surgical or non-surgical. In non-surgical, the UHG guided or fluoroscopic guided intussusception reduction can be done. It has very high success rate, up to 95%. Indications are stable child and there should be availability of radiologist. A contraindication is long duration of symptoms and when you are suspecting perforation along with the intussusception. It can non-operative cases. It can be done by the hydrostatic reduction or pneumatic technique. It is done under the UHG guidance or fluoroscopic guidance. Maximum limit of pressure to avoid the perforation is 120 mmHg. It has an advantage over the hydrostatic reduction. It is more comfortable as we are using air. Less radiation exposure. If we do in smaller quantities, perforation chances are less. Less peritoneal, it causes less peritoneal contamination. But disadvantage is sometimes the passage of air to the terminal ileum without complete reduction. And the second is possibility of perforation due to tension pneumoperitoneum. Hydrostatic technique. They say there is a rule of 3 that you can hydrostatic reduction can be done under the UHG guidance. Maximum 3 attempts you have to take, and each attempt should not last more than 3 minutes. And there should be a distance of 3 feet between the table and the enema bag, so that more than that distance will give the more pressure, and less than that distance will may not give much pressure to reduce the intussusception. Surgical treatment indications are in case of UHG, whenever there is a failure of UHG guided reduction, or there is a contraindication for the conservative management, such as you are suspecting perforation, pneumoperitoneum, if you are suspecting pathological lead point, or there is a prolonged bleeding more than 24 hours. So in surgical case, the laparotomy with the reduction of intussusception is usually done. If there is a presence of any gangrene, then resection anastomosis is done. Post-operative complications, there can be recurrent intussusception in 20% of the cases, more common with the conservative or radiological method. One third occurs within 24 hours. So at least one ultrasonography we should document within once the successful reduction of intussusception is done. Post-operative small bowel obstruction, more common in laparotomy with resection anastomosis. Surgical site infection and facial dehiscence can occur as a post-operative complication. Thank you.
Thank you, Dr. Sachin. Dr. Bharat sir, please, you are expert from, especially your experiences regarding intussusception in your practice.
So I would like to just say about one patient. Last week I saw the patient was admitted in some other hospital. Overnight, the patient was kept of intussusception. Next day, the patient was transferred to KEM hospital after the sonography. KEM hospital kept the patient overnight. Next, the whole day, the patient was operated. The next day, the patient had necrosis. They did bilateral colostomy, and the patient was admitted in KEM for 2 months for colostomy, with colostomy and poor feeding. And now the patient is having chronic colostomy sinus, and all the fecus is coming out after 3 months of intussusception episode. I'm highlighting this because if you miss the intussusception in early stage, you can land up in any of the problems. So very high suspicious index is required. The peak incidence is usually between 9 to 10 months, and 75% of are less than 1 year. Male to female ratio is almost 3:2. The presentation is very tricky. It starts with vomiting and excessive crying, which lasts for 4 to 6 hours. And in between the excessive crying, they are quite okay. And after every 15 to 20 minutes, there is an episode of vomiting and excessive crying. After 4 to 6 hours, they start having intermittent lethargic period. They start having electrolyte imbalance. And then at a later stage, then there is a red colored jelly and the mass is palpable. So once you have mass is palpable and red currant jelly and you establish a diagnosis of intussusception, you have already missed the bus, or maybe you are going to miss the bus, because that cannot be made. There can be hydrostatic correction can be done or may not be effective in that child. So sometimes the initial presentation can be lethargy only and altered sensorium. People have reported it as altered sensorium and lethargy as initial presentation of intussusception with electrolyte imbalance. 10% of the patient can present with diarrhea before the symptoms occur. So you have to be very vigilant that which patient will go into intussusception and all. Sometimes constipation can come with recurrent intussusception. So if any patient is there, and if you get, especially the older patient with 2 to 3 years of age, and if you see there is a history of constipation, and your sonologist says that patient comes with pain in abdomen and vomiting, and your sonologist says that there is a colocolic intussusception or maybe ilioileal intussusception, then you should give enema and try and whether the intussusception gets reduced on or its own. So the incidence wise, 1% of them presents with within 3 months of age, 3 to 12% in 30%, 3 to 12 months in 30%, 1 to 2 years 20%, 2 to 5 years 25%, and more than 3 years is 10%. Recurrence rate after the reduction is 4% within 48 hours. Maybe sometimes the barium is remaining inside, can lead to recurrence. And non-operative, basically non-operative recurrence, non-operative treatment. If the child is more than 5 years, then the chances of non-operative reduction is very low. Sometimes adenovirus season can have intussusception. Celiac disease patient can have intussusception, and Crohn's disease patient can have intussusception. So you have to be vigilant in all of them. X-ray abdomen is a must before you start any of the treatment to rule out whether there is a perforation is there or not. And hydrostatic pressure or whatever treatment you go, you have to do it in OT with all the standby thing, that if the thing is not reduced, then you have to go for operative thing.
Yeah. Thank you, Bharat sir. Now, Usha madam, with just some suggestions for our pediatricians, a take-home message regarding the intussusception patient, when to refer, whom to keep.
Sir told about the symptoms. Most of the cases, post-diarrhea, they get an intussusception. So if your child is having a admitted patient has got a severe pain in between the colics, so don't wait for the red currant jelly to get the red currant jelly. It's a late sign actually. So any child with a colics and in between the child is well, in between the child is well, and in between he gets a colic. So such patients you should always do a ultrasound. Take a go for ultrasound. One extra ultrasound will save the intussusception diagnosis. And the intussusception diagnosed on ultrasound, you can refer those patients to the pediatric surgeon, and we can do the reduction in the early cases. Most of the time, if your radiologist is like cooperative, you can we can take those patients to the radiologist and do the ultrasound guided reduction, and at that time we'll be able to save the surgery. Many cases can be like ultrasound guided reduced. Many of the time. I have hardly, like, if 50 cases come to me, 25 to 30 cases can be reduced if they are not complicated already. So ultrasound guided reduction can be done in most of the cases. And for early diagnosis, we should always go for an ultrasound.
Well said, ma'am. Thank you. One question is there from Dr. Suhas from Nanded regarding appendicitis. Usha madam, when we should treat a case of subacute appendicitis and when we should go ahead for the operative in such cases?
if the child is having a subacute appendicitis, 1 or 2 times you can conserve them. Give antibiotic, IV fluids if the child settles. But if he is getting a recurrent episodes, then you should always go for a surgery. Elective
well
surgery
said.
can also be done.
Okay, that means recurrent appendicitis, always go ahead with the surgery. Thank you, ma'am. So no more questions are there in the chat box. So the last session, that is a vote of thanks. So on behalf of MAHAIP, I would like to extend my heartfelt thanks to our esteemed experts, Dr. Shailesh Barot sir, Dr. Usha Gajbe ma'am, our esteemed speakers from all of the Maharashtra, then all CIP and MAHAIP OB team members, and all the delegates who have attended this session, and my dear friend Dr. Nikhil for moderating along with me. So thank you one and all. Have a good night. Thank you once again.
Thank you, Sachin.
Now
and
we
very
can
much
officially close
for
the
wonderful moderation.
sir.
Thank you, sir. Thank you very much.
Thank you. And thank you, Pallavi madam, for your digital platform, digital help.
Thank you all.
Thank you, sir. Thank you, Bharat sir.
Thanks.
Yes.
Thank you.